Okay, Assalamualaikum. I'm Dr. Sana Amjad, and today we are discussing some single best answers. Okay, we have finished our 3 modules, so these SPAs will be from those 3 modules: anatomy, embryology, and genetics. Okay, so let's quickly start our today's discussion. Okay, so from anatomy, first few questions are from anatomy. So, which of the following nerves passes through the inguinal canal? That is ilioinguinal nerve, pudendal nerve, lateral femoral cutaneous nerve, inferior hypogastric, and pelvic flanking nerve. Ilioinguinal nerve. Yes, great. So basically जो contents हैं inguinal canal के वो यही एक nerve है दोनों female और male में, ठीक है? Ilioinguinal nerve is constant और females में there is round ligament of uterus and in males there is a spermatic cord. Okay. Okay, so next is what testicular cell type secretes testosterone? And that's very easy question. You all know myoid, interstitial, fertile, Leydig germ. Okay, so the Leydig cells actually secrete testosterone. Now the few description is fertile cells actually they secrete inhibin and they form blood testis barrier and they have FSH receptors. And Leydig cells it secrete testosterone and it has LH receptors. So FSH receptors are present on fertile cells and LH receptors on Leydig cells. So L, LH, Leydig cells, L. Okay. Okay, so actually there are 250 to 400 lobules in each testis, and a lobule is actually the structural unit of testis, with each lobule contained in one of the intervals between fibrous septa, which extend between the mediastinum testis and tunica albuginea. Okay, so the structural unit of testis is actually lobule, and each lobule contains 1 to 3 seminiferous tubules. Now, these figures are also very important. They can ask you, okay, how many lobules are present in each testis? So that is 250 to 400, and then how many seminiferous tubules are present in each lobule. And there's also important structure of sperm tail, that is axial filaments of sperm tail. And that's arrangement is 9 plus 2. So basically the 9 are peripheral and 2 central, like this central 9 जो है ना इस तरह axial filaments होते हैं. So it has a pair of longitudinal fibers called beta fibers surrounded by a ring of 9 pairs of longitudinal fibers. So that are the alpha fibers. Okay. Okay, so this was just brief description. Now, what is the average oblique diameter of pelvic inlet according to the RCOG? Oblique diameter. That is 7.5, 9, 10.5, 12, and 12. Yes. And that's very easy thing to remember that all the oblique diameters, they are actually 12 centimeter. Okay. See, this was table we discussed in our anatomy lecture that in pelvic inlet, what was biggest, the longest, that was the transverse diameter. And in outlet, the longest was the AP diameter. Okay, so longest 13, then the shortest would be 11. Oblique always remains the same, 12, 12, 12 in everything, pelvic inlet, cavity, and outlet. And pelvic cavity, so pelvic cavity has equal, because it is a round-like structure, so it will have equal diameters. AP will be 12, oblique, and transverse would be 12. Okay, so any question comes from this table, they can ask you the AP diameter of inlet or AP diameter of outlet, transverse diameter of inlet or transverse diameter of outlet. So this table is very important. This is the diagram, and see, this is the transverse diameter of pelvic inlet, which is 13. You just remember 13. And the AP diameter is 11 and oblique is 12. And also you have to remember the boundaries, that what boundaries they are forming the pelvic inlet. Posteriorly, that was the sacral promontory. Anteriorly, this is the pubic symphysis, and laterally the iliopectineal line. Okay. So this was very important diameters, and we discussed also 3 very important pelvic diameters that was taught. So that was the true conjugate, obstetric, and diagonal conjugate. Okay. So mm, Zornish. Okay. Okay, so that was the third. You all have known the true conjugate, obstetric, and diagonal conjugate. Okay, and that was 10, 11, and 12. Sorry, this is 10, upward is 11, and downward was 12. Okay. Okay, so the next question is the roof of femoral triangle is formed by which structure? The facial lata, sartorius, adductor longus, femoral sheath, or transversalis fascia? Facial lata, yes, that's great. Okay, so these boundaries are actually very, very important. All the boundaries of femoral triangle, the inguinal canal, these are important. So superiorly, it was inguinal ligament, and the medially the adductor longus. Basically, the laterally is the sartorius. So these three are very important. And then the floor and roof. So floor is formed by the pectineus muscle, adductor longus, iliopsoas muscles, and the roof is formed by the fascia lata. And the transversalis fascia, it forms part of the roof of inguinal canal. You see this diagram, see this was the superior would be the inguinal ligament, medially would be this is the adductor longus muscle, and this is the sartorius muscle. So basically triangle was formed by these three structures, okay? And then there is a roof and floor. And what it includes these three femoral vessels, okay? So femoral nerve and femoral vessels. Okay, so next would be the regarding the uterine artery, which of the following statements are true? It arises from uterine artery. Okay, so they are asking about it arises from basically origin. They are asking external iliac, internal iliac, ovarian, vaginal, internal pudendal artery. Okay, so that's a very easy question. It arises from internal iliac artery. Now you have to remember the branches, all the branches of internal iliac artery, the anterior branches and the posterior branches. Okay. Okay, so look at the diagram below. The lambda suture is represented by which label? This is anterior, if you could not. This is posterior.
Which side?
Lambda suture. See this. This is anterior and this is posterior. So first label the bones. Like this is the first right frontal bone, left frontal bone, and this is the parietal bones, and then the last is the occipital bone. So basically there are three sutures that are very, very important. First is the frontal suture, it's between the frontal bone. Second is the coronal suture, it's horizontally between the parietal and frontal bone. So these two are the coronal sutures. And then this is the midline between the parietal bone is the sagittal suture. Okay. And lambdoid is always between the occipital and parietal bone. So this is the lambdoid suture. So lambdoid suture was marked by I. Okay, so this is actually the lambdoid suture. You have to just know that this is the occiput, because occiput is one bone and anteriorly is the two frontal bones. So this is the fetal skull is very, very important for even this fontanelles. They are important where the anterior fontanelle is present. So it is at the junction of these parietal bones and frontal bones, and where the posterior fontanelle is present at the junction of sagittal suture and lambdoid suture, basically. So these two fontanelles are also very important. Now, what is forming the anterior boundary of pelvic outlet? Now, the outlet boundary, anterior boundary, okay? So pubic arch, ischial tuberosity, pubic crest, tubercle, sacrotuberous ligaments. So only the anterior boundary they are asking that which structure is forming the anterior boundary of pelvic outlet. Okay, so anteriorly would be all pubic arch. If there is a diagram, no diagram, okay. So see the pelvic outlet boundaries, these are very important again. So the anteriorly would be the pubic arch, and laterally they are the ischial tuberosities, and posterolaterally would be the sacrotuberous ligament, and posteriorly would be the tip of cox. So these are the few structures of the pelvic outlet boundaries. Now, the lumbar plexus is derived from which spinal segments? This is very important, very easy to remember the lumbar plexus. Okay, so you all have known it. T12, yes, T12 basically it adds in the lumbar plexus. Okay, so it's very important. Okay, see this diagram from 12th thoracic. Okay, this do come here. And or iliohypogastric nerve, basically its innervation is T12L1. Okay, so this is also an important thing. They usually come in exam. The nerve supply, nerve roots of iliohypogastric nerve. Okay, so rest of all the nerves you already know: iliohypogastric, ilioinguinal, genitofemoral nerve, and the obturator nerve. This femoral nerve is from the posterior branches, lateral femoral cutaneous nerve of thigh. Okay, so these three and this obturator. These are anterior from the anterior divisions, and they are important for the pelvic region. So the rectus sheath is formed by which of the following structures? So which muscle aponeurosis they are forming the rectus sheath? So basically it is formed by the
internal external oblique aponeurosis.
And कौन सी option?
Option D.
नहीं, the rectus sheath basically ये भी तो है ना, transverse abdominis भी तो है. एक्सटर्नल और इंटरनल ओब्लिक तो ठीक है, ये दो मसल्स तो आपने ठीक बताया, लेकिन ट्रांसवर्स एब्डोमिनस इट इज आल्सो फॉर्मिंग द rectus sheath. So basically all the three anterior abdominal wall muscles, they are forming the aponeurosis of rectus sheath. Okay, so basically this rectus sheath is formed by all the three aponeurosis of the transverse abdominis, one external oblique and internal oblique muscles. And what it contains two muscles. One is the rectus abdominis and pyramidalis. If it is present, then these two muscles contains in the rectus sheath. Now this is a very, very important topic, rectus sheath, because it usually come in exam. They usually ask about the they ask about that how the anterior wall of rectus sheath is formed. So this table was very important from our lecture. So above the costal margin, okay. So basically above the costal margin, only the external oblique aponeurosis is forming the anterior wall, and there is no posterior wall. Okay. So basically the rectus muscle, it placed on ribs. Okay. So there is no posterior wall, just anterior wall formed by the external oblique aponeurosis. Okay. And if you take this structure, that from the costal margin till the arcuate line, okay, so from in between these structures, the aponeurosis is formed by anterior wall also and a posterior wall. Okay, so posterior wall basically it is present only at this point, not above the costal margin, not below the arcuate line. Okay, so only in this point from the costal margin till arcuate line, the anterior and posterior walls are formed. So basically anterior wall is formed by two muscles, external oblique and internal oblique aponeurosis, and posterior wall is also formed by the two muscles, transverse abdominis and internal oblique muscles. So basically actually external oblique, it goes like this. See, this is external oblique, it goes this to enclose, this is the rectus muscle. And then the internal oblique, it splits into two ends. One end gives to a fuse with the anterior wall, and a second end fuse with the posterior wall. And then this is the transverse abdominis muscle, and it goes posteriorly. So this is how the aponeurosis is formed by the external oblique, internal oblique, and the rectus abdominis muscle. So this point is very important from exam purpose. And then the below arcuate line, what happens that all the three muscles, external, internal, and transverse abdominis, they go anterior to the rectus muscle. So only the anterior wall is present. Okay, and again below arcuate line, there is no posterior wall. This is very important topic for exam. The rectus sheath is very important. Okay, so next question is regarding levator and eye. Which of the following statements is true? Arterial blood supply is from inferior rectal artery, from superior rectal artery, from internal iliac artery, inferior gluteal artery, or कौन सी कौन सी गई
Inferior gluteal, it's
inferior
D option.
D option. Yes, inferior gluteal artery. Okay. So basically, levator and eye, it has few nerve supply than the arterial supply. So basically, nerve supply is from the pudendal. So pudendal and perineal branch is also from the pudendal nerve, inferior rectal nerve. So basically, pudendal nerve is supplying levator and eye. The S3 and S4 spinal nerve roots would be there. Arterial supply would be the inferior gluteal artery, and it has three components like we all have discussed previously: puborectalis, pubococcygeus, and the iliococcygeal muscle. So three components of levator and eye. Okay, so now the lymph from the scrotum, it drains into which nodes? Lumbar nodes, para-aortic, hypogastric, deep inguinal lymph nodes, or superficial inguinal lymph nodes?
Superficial.
Superficial, yes, that's great. Okay, so scrotum is actually lymph nodes goes to the superficial inguinal lymph nodes. So testis is inside, but testis lymph nodes goes to testis artery actually arises from aorta. Okay, so that's lymph nodes goes to para-aortic lymph nodes. Okay, so scrotum drains to superficial inguinal nodes, unlike the testis that drains to lumbar and para-aortic nodes. Okay, so which of the following is a branch of pudendal nerve? Superior rectal nerve, lateral rectal nerve, perineal nerve, ventral nerve of clitoris, or superior nerve of clitoris?
Perineal.
Perineal nerve, yes. Perineal nerve. And there is actually the inferior rectal nerve is also a branch, and then the dorsal nerve root of clitoris. Okay, so this and the perineal nerve, these three are the actually important branches of pudendal nerve. Okay, so here, cover. Pudendal nerve, its origin is from S2, 3, and S4. The terminal three very important terminal branches are inferior rectal, then this perineal, and then this is dorsal nerve of clitoris. And this pudendal nerve, which muscles it innervates? Actually, all the perineal muscles, they are innervated by pudendal nerve. So bulbous spongiosum, ischial cavernosus, levator and eye group, external anal sphincter, and the female external urethral sphincter. So both external sphincters you can remember, because external sphincters, they are voluntary muscles. So that will be supplied by this pudendal nerve. Okay. So the testicular arteries are branches of what?
Aorta.
Aorta. Yes, that's great. So arterial supply is the testis has three branches supplied by from three roots. The testicular artery, which arises from aorta, and there's also cremasteric artery and also the artery to vas deferens. And the venous drainage is by the testicular vein, and the pampiniform plexus actually drains into the testicular vein, and then it goes to the inferior vena cava. Okay, so the medial umbilical ligament is a remnant of which structure? So fetal paraumbilical veins, umbilical artery, medial.
Parambilical veins.
Vein or arteries?
B, ma'am.
Arteries. So basically, first in the middle is the median. Okay, median is formed by the urachus, and then it is a medial. Okay, L. So then it would be from the umbilical arteries, and also there's a lateral fold, and which is a structure, remnant of which structure? Lateral. Anybody can tell? No?
Inferior epigastric, ma'am.
Inferior epigastric, yes. Inferior epigastric artery. Okay, so this is the medial would be the remnant of umbilical arteries. Median would be the urachus. Okay. So regarding lymph drainage of cervix, where does the majority of lymph drain to?
Internal iliac.
Yes, internal iliac lymph nodes. Okay. Internal, external?
Internal.
External, ma'am.
External. External artery, iliac lymph nodes. अच्छा, ये टेबल बहुत इंपॉर्टेंट है, इसको देख लेते हैं. So breast actually also important, so that would be the, you all know कि हम जब breast की mastectomy करते हैं तो साथ में axillary lymph nodes, pasternal lymph nodes remove करते हैं. Okay, so ovary, all know कि ovarian artery is a branch of aorta, so para-aortic nodes would be there. Fallopian tubes is also supplied by the ovarian arteries, para-aortic lymph nodes, and the cervix, they also external iliac lymph nodes, and ultimately they have to go to para-aortic lymph nodes. And the uterus form the internal iliac artery, so internal iliac lymph nodes, and just the fundus portion, because it is supplied by the ovarian artery, so it goes to para-aortic lymph nodes, and also few goes to lumbar. So these are not actually important. You just have to remember the most important. So internal iliac is important. Even if they ask the drainage of fundus, then you select the para-aortic lymph nodes. Okay, so uterus mainly actually goes to internal iliac lymph nodes. Then there's a vagina, upper 2/3 and lower 1/3. So upper 2/3 goes to the internal iliac and external iliac, and the lower 1/3 would be the inguinal lymph nodes. Okay. Okay. So the external anal sphincter is innervated by which nerve? External anal sphincter.
Inferior rectal.
Inferior rectal. Superior rectal, pelvic splanchnic, inguinal, genitofemoral, बाकी हो भी नहीं सकती. तो बेसिकली वैसे भी हमने पढ़ा है अभी दोनों स्फिंक्टर्स जो है ना वो पोडेंडल नर्व सप्लाई कर रही है. ठीक है, एक्सटर्नल एनल स्फिंक्टर भी, एक्सटर्नल यूरेथ्रल स्फिंक्टर जो है ना उसको भी. Okay, so pudendal nerve branch would be there. Okay, so basically ये दो जो sphincters हैं, internal anal sphincter और external anal sphincter. So one is involuntary and the other is voluntary. So basically involuntary जो है ना उसको आपकी जो pelvic splanchnic और sympathetic, parasympathetic वो nerves जाती हैं. ठीक है, so sympathetic contraction, parasympathetic relaxation. So pelvic splanchnic nerves would be supplying internal anal sphincter. लेकिन एक्सटर्नल एंड स्फिंक्टर है तो ये सोमैटिक नर्व्स, they will be supplying from the somatic nerves. So that would be actually the pudendal nerve, और अगर उसकी branch पूछें तो inferior rectal branch. Okay, and also the perineal branch of S4 you can say. So basically pudendal nerve you have to remember. Okay, so what is the name given to glycoprotein layer of oocyte that binds spermatozoa and essential for acrosome reaction to take place?
Zona pellucida.
Zona pellucida, yes. Okay, so if you see this oocyte structure, this is whole is the nucleus, and then this is the cytoplasm and the cell plasma membrane. Just outer to this plasma membrane, it is actually glycoprotein layer, that is the zona pellucida. Okay, so this is important layer of this oocyte, and after that these are the cellular layer which is forming the corona radiata. So these two layers are very important. So basically zona pellucida is actually important for sperm to have to bind and initiate the acrosome reaction. Okay, and the corona radiata is part of cumulus ovorus, which is the outermost cell layer of the oocyte. So that is the cellular layer of the oocyte. Okay, so patient attends clinic with vaginal prolapse. On examination, vaginal prolapse is visible 1.5 centimeters above the plane of hymen. So basically the vaginal prolapse. So POPQ classification, they are asking you that what grade is this prolapse? We have not discussed actually this prolapse, so that's why I put this question. If they ask you, because these topics will be actually covering in detail in the clinical management, but let's quickly just finish this topic. So the vaginal prolapse, you don't need to go into very detail of this POPQ classification. It is actually
Grade 1, ma'am?
yes, grade 1. This is actually the topic of MRCOG part 2. So just you have to know the grading system of this POPQ classification. Okay, see this time this. So what happens is that grade 0 means that there is no prolapse. Okay, and if the prolapse is more than 1 centimeter above hymen, more than 1 centimeter, like this is the cutoff, this point is the hymen. Okay, and if you say that this is here is the uterus with cervix. Okay, so if there is this structure is more than 1 centimeter from hymen, like it is 2 centimeter above hymen, so it means it is grade 1. And what happens in the next grade 2? Within 1 centimeter to the plane of hymen, within, like 1 centimeter proximal to the hymen and 1 centimeter distal to the hymen. So if this uterus goes here, this point, like it is 1 centimeter upward or 1 centimeter downward from this point to this point, like this or this. Okay, so 1 centimeter upward and below, if the prolapse is here, then it would be the grade 2. And what is the grade 3? It is more than 1 centimeter below the plane of hymen. Okay, so this is the 1 centimeter, so it protrudes more than 1 centimeter. So just 1 centimeter is very easy point to remember. It is more than 1 centimeter above hymen is grade 1. Within 1 centimeter above and 1 centimeter below, it is grade 2. And it is more than 1 centimeter below the plane of hymen. Okay, so that is 3, and 4 is actually the complete eversion of vagina. So basically grades are different, and then we have the degrees as well. Okay, so degree we classify according to the Baden-Baker or Beacom classification system, and there are the first degree, second degree, and third degree. Okay, so cervix is visible when the perineum is depressed, prolapse is contained within the vagina. Just you say that prolapse is just within the vagina. And second degree, it prolapsed through the introitus, means the prolapse is outside the introitus. And third degree is actually complete prolapse. So in degree system, we just have 3 degrees, and in grading system, in the POPQ classification, we have 4 classification, okay, 4 grades, 0, 1, 2, 3, and 4. Just need to remember these points, that what is grade 0, 1, 2, 3, and 4. Okay, so which of the following leaves the pelvis via the greater sciatic foramina?
Pudendal?
Yes, pudendal nerve. Pudendal nerve is actually, whenever pudendal nerve is present, it would be option, because it enters the greater sciatic foramina, and also it goes through the lesser sciatic foramina as well. Okay, so these are the structures which actually goes through the greater sciatic foramina. So what are the important structures? The nerves. Okay, so we know that pudendal nerve would be here, pudendal vessels would be here. Okay, and the one muscle, only one muscle, is the piriformis, which actually goes to the trochanter of femur, trochanter of femur, and so that these are the structures of the greater sciatic foramina. Now the few structures which actually they goes to the just remember that the structures which goes to the buttocks or gluteal region, like sciatic nerve, superior gluteal, inferior gluteal nerve, posterior femoral cutaneous nerve, nerve to quadratus femoris, And also this nerve to obturator internus, it is actually goes with the pudendal nerve. Okay, so pudendal nerve and nerve to obturator internus, they go from the greater sciatic foramina, and then they also come through the lesser sciatic foramina. So these contents are very important for exam as well. Okay, so you are called to see a woman after prolonged labor with failed instrumental delivery converted to C-section. She is unable to dorsiflex her right foot and complains of pins and needles to the foot and lower leg. What is the likely diagnosis?
Common peroneal nerve.
Common peroneal nerve. So basically, unable to dorsiflex her right foot. So what happened? It was actually the foot drop. Okay, so foot drop will be caused from the common peroneal nerve root compression. Okay, so these nerve entrapments, they are very important. Just need to remember a few important points from here. Okay, so this was actually the common peroneal nerve. It compressed actually in the lateral head of fibula and leg bar. So lithotomy position is the risk factor in this common peroneal nerve. And what would be happen? The sensory loss and motor loss. So foot and anterolateral leg. The sensory loss would be present, and the motor loss means the foot drop. So foot drop is very important. So loss of anterior compartment extensors. So that would be causing her to dorsiflex her foot. Okay, so obturator. So obturator actually, it compresses between the head of fetus and the bony structures of pelvis and upper medial thigh, and just the leg adduction. Obturator is actually the adductor of leg, so weakness in leg adduction. Okay, so lateral femoral cutaneous nerve is also entrapped in pregnancy, and it is because the nerve indicates lateral femoral cutaneous, so only the sensory loss would be here, the lateral thigh, and is not providing any motor supply. And femoral is important. So basically, these two are important. So femoral nerve actually compresses from fetus in a difficult birth, and anterior thigh and knee places have sensory loss, and the quadriceps weakness and lost knee jerk. Basically, this point is important, that if the knee jerk is lost, and then it means that the femoral nerve is compressed. So femoral nerve entrapment in the knee jerk lost. Okay, so foot drop and this loss of knee jerk, these two are very important nerve compressions. Okay, so inferior 1/3 of rectum is principally supplied by which artery? So superior rectal artery, middle rectal artery, inferior rectal artery, sigmoid artery, external iliac artery.
Middle rectum.
That is the middle rectal artery, because that is the difference actually. So, okay, so if you see these structures, then this structure. Okay, so basically the vascular supply is actually according to the embryology origin. Okay, so whenever they ask you in the GIT the nerve supply or the blood supply, so just go to the embryology and see at from which structure it has developed. Okay, like you all have known that ascending colon, transverse colon, proximal 2/3 up till this structure, starting from the duodenum, is supplying by the superior mesenteric artery. So you remember that there was the foregut, and then the midgut, and then the hindgut. Okay, so foregut was supplied by the celiac trunk, and the midgut was supplied by the superior mesenteric artery, and hindgut from the inferior mesenteric artery. Okay. Okay, so transverse colon, distal 1/3, inferior mesenteric, distal, descending colon, sigmoid, rectum, upper 2/3. And this, now the difference here, the rectum, lower 1/3 would be supplying from the middle rectal artery, okay, and then the anal canal would be supplying by the internal pudendal, inferior rectal artery. Okay, so the round ligament develops from which structure? That is gubernaculum, urachus, allantois, median and medial umbilical ligaments.
A.
Yes, that is gubernaculum. Okay. So a patient undergoes oophorectomy and ovarian veins are ligated. Which vein does the left ovary drain into? So
Left renal.
left renal, yes. So basically left ovary, left testicular vein, it goes to the renal, left-sided renal vein. And right, it goes directly to inferior vena cava. So this is important difference. Okay, so a 31-year-old woman has blood taken at 12 weeks gestation, which shows low levels of PAP-A and alpha-fetoprotein and elevated beta-HCG. So basically, beta-HCG is increased, PAP-A is reduced, and alpha-fetoprotein is also reduced. So what would be it suggestive of? Which
Downs?
syndrome? Down at what?
Downs?
Yes, down. So that is very easy way to remember. Whenever beta-HCG is elevated, so just go with the Down syndrome, because Down syndrome has two things elevated: beta-HCG and what was the second biochemical?
Inhibin?
Inhibin. Inhibin, yes, not estriol. So inhibin, whenever the beta-HCG and inhibin, these two are raised, it is just the Down syndrome. And in Edward, we said that everything would be reduced, everything reduced. And this AFP is also very important, that it would be raised whenever there is abdominal structures are increased, or the neural tube defects, abdominal wall structures like gastroschisis, or there is omphalocele. Okay, so these are few very important things you have to remember. Okay, so this was the table we discussed previously. So down and Edward. If you see down, and what is elevated? Inhibin and beta-HCG, only these two things, and Edward has everything reduced. So that is just an easy way to remember. So alpha-fetoprotein, it will be elevated in neural tube defects and multiple pregnancy as well, and also the abdominal wall defects. Okay. So, which of the following statement regarding management of beta thalassemia in pregnancy is not part of MRCOG guidelines? Okay. Has anybody?
It should be given 3 months prior to conception.
Yes, that's great. So folic acid 5 milligrams daily should be commenced 12 months prior to conception. No, that is just a wrong thing, because it is 3 months. Rest of the options are correct. Now read that. All women with thalassemia major should undergo specialist cardiac assessment at 28 weeks. Women should be offered serial fetal biometry scans every 4 weeks from 24 weeks. All women should be receiving blood transfusions on a regular basis. Aiming for pre-transfusion hemoglobin would be 10. Okay, so pre-transfusion hemoglobin should always be 10. Women with thalassemia who have undergone splenectomy and have a platelet count more than 600. When they have splenectomy and platelet count more than 600, then they should be given this low molecular weight heparin and aspirin. Basically, this thalassemia topic is very important. It is actually important for MRCOG part 2, but usually they can ask you few important things in the clinical management module. So let's quickly just discuss important points from the beta thalassemia. Okay, so general key points is that it has global incidence is very not, don't need to remember this incidence. So basically, it many babies they born with thalassemia each year, and caused by mutation in hemoglobin gene, which is present on chromosome number 11. Okay, so this is important thing. And the autosomal recessive inheritance. Basically, this is very, very important for your exam, because it is an autosomal recessive disease, and its inheritance pattern you have to remember that how it inheritance goes into the offspring. Now you all have know the homozygous would be the major, and the heterozygous would be the beta thalassemia minor trait or carrier. So homozygous, like major, would be having the severe transfusion dependent anemia, and minor, they produces just the mild microcytic anemia. Usually they do not diagnose until puberty. Now how you have to manage in pregnancy, this is we discussing about the beta thalassemia major patients. Okay, mother is beta thalassemia major. So management in pregnancy would be very, you can say, the multidisciplinary management. Okay, so basically they should be screened for diabetes. So diabetes is very, very important. They can develop into diabetes because their pancreas do not work properly. So if they detected, then refer to diabetologist. Thyroid functions should also be screened in these patients. And then they should be having an assessment by a cardiologist and have, now these things are very important tests. They have to be done. The ECG, the echo, and the T2 cardiac MRI, because they have multiple blood transfusions, so the heart would already be in the failure, heart failure risk. So for the pregnancy, they should have these tests done: the ECG, echo, and the T2 cardiac MRI. Now, the patient should have biliary ultrasound and have ferry scan or liver T2. Now, the liver scan is also very important because the iron, they usually give multiple transfusions. So basically, the iron is actually deposited in all these organs. The iron deposits in the pancreas, in the thyroid, in the heart, in the liver. Okay, so basically, all the organs, they are actually compromised due to multiple transfusions. So basically, they are iron overloaded patients. So that's why they have to be, their assessment of all these organs have to be done, that how they are functioning, and they would be given the iron chelator drugs during the pregnancy. So all women should be offered bone density scan as well. Now the folic acid 5 milligrams daily. Now this is a high dose folic acid, 5 milligrams daily, because they are at risk of anemia, and also in the hemolytic anemias like sickle cell disease. There you would be also be giving the folic acid in 5 milligrams. Milligrams is very high dose. Usually the normal pregnancy folic acid dose is actually 400 micrograms. Okay, so this is a high dose folic acid commenced 3 months prior to conception in these patients, and all patient women should be receiving blood transfusions on a regular basis for pre-transfusion of hemoglobin 10. Okay, so this was in the all the testing and all the management process you have to done. And the scan, what ultrasound scan should be done in these pregnancy. So the first scan, you always know that there would be the early scan to determine the viability, and then there would be a routine first trimester scan, that would be the dating scan. We will be discussing the anti-scan, also the detailed anatomy scan. And then this is just a different, that they should be having the serial fetal biometry scans every 4 weeks, like every 1 month from 24 weeks of gestation, because they are at risk of 5GR. So the fetal biometry scans are multiple every 4 weeks from 24 weeks. And then this thromboprophylaxis. So basically, this topic is important. This thromboprophylaxis is important for exam purpose, that how the thromboprophylaxis should be given in these patients. Now, what happens that if there are two things, one is the splenectomy. Whenever the question comes regarding the thromboprophylaxis, just see these two things: splenectomy and platelet count. Okay, if both things are present, splenectomy is also being done, and the platelet count present means platelet count more than 600. Okay, so if both of these things are present, then they should be offered low molecular weight heparin and aspirin, both things. Okay, now if one thing is present, like undergone splenectomy, or either splenectomy, or the platelet count is more than 600, then just the aspirin. Okay, that is 75 milligrams per day. Now, if they women with thalassemia who are not already using prophylactic low molecular weight heparin should be advised to use it during antenatal hospital admissions. Now, admissions, whenever there's hospital admissions in the high risk pregnancies, they actually advise the thromboprophylaxis. But these two things are very important, that if the splenectomy is present and the platelet count is more than 600, then go for low molecular weight heparin. Okay, plus aspirin is usually you give. If splenectomy or platelet count more than 600, then only aspirin. Okay, so this slide is important for exam. Now, which of the following is the leading cause of Down syndrome? The non-disjunction, maternal gamete, paternal gamete, mitotic non-disjunction, Robertsonian. Robertsonian is also a cause of Down syndrome. Still, we have the non-disjunction. So basically, we discussed that more than 95% would be having the non-disjunction, and that is the maternal gamete, always. See, this non-disjunction, it accounts for approximately 95% of Down syndrome, and majority, 88% is from the maternal gamete. So we discussed in genetics that the non-disjunction means what was that mean? That in the anaphase, the chromatids, they have to separate to the each pole. That was the anaphase. So non-disjunctions mean non-separation. So they do not separate, and they both goes to one gamete, and it is empty from these chromatids. So that is the non-disjunction. So it is actually important mechanism for this syndromes. 8% just due to the paternal gamete, and mitotic non-disjunction actually after conception, that leads to mosaicism. And translocation is also important, just approximately 3 to 4% of Down syndrome. And Robertsonian is there, Robertsonian translocation. Now, a woman has undergone genetic testing due to her family history and has the BRCA gene too. What would you advise her lifetime risk of ovarian cancer? BRCA. These are very, very important, BRCA genes. Anybody can answer this? What? Sorry?
It's 5%.
5 नहीं, 5 तो कहीं भी नहीं है.
5 or 15%.
15 हाँ 15 हो सकता है. अच्छा, अब इसमें भी यही टेबल, that is very, very important. Okay, so whenever they give you that the BRCA1 is present or BRCA2 is present, okay, so this you have to go through this table. Now you all know the breast cancer is actually linked with the BRCA mainly. Okay, so breast cancer risk would be more than the ovarian cancer. So BRCA1 60 to 90, and even BRCA2 just below from 60. Like this is 60 to 90, and this is 50 to 80. You can say, okay. So it is higher. Now in ovarian cancer, it actually BRCA1 is 40 to 60, and BRCA2 is 10 to 30. So 15 would be lying here. 15, 20, 30, whatever the option would be here. So this would be present. Okay, so these two genes are very, very important for the exam. These percentages are important. Now again, there is another genetic disorder, and that is the Lynch syndrome, which is hereditary non-polyposis colorectal cancer. Okay, so what is the lifetime risk of endometrial cancer in patients? What would be this? 20, 40, 60, 80, 90. Endometrial cancer with HNPCC syndrome. That is actually, it is very important and very much risk. Basically, endometrial cancer is with this HNPCC, it is 40 to 50%. Okay, so that is 40%. Okay, so a 31-year-old woman has bloods taken at 12 weeks gestation, shows elevated AFP. Now AFP is elevated. PAP is normal, estriol is normal. So what are the results suggestive of? Whenever AFP is elevated, just go to those resistance elevated AFP.
See?
Yes, so these syndromes would not be present. Actually, the spina bifida, the neural tube defects would be present. Now, these are the conditions which have raised levels of AFP, defects, neural tube defects, anencephaly, multiple pregnancies, and the abdominal wall defects. Okay, so again the BRCA has present. Again this mutated BRCA आ गया. So उन्होंने पूछा है कि fortunately tests are negative, means the BRCA is not present actually. So basically, they are asking about the lifetime risk of breast cancer. That what in general population, what you have the lifetime risk of breast cancer. So that would be any guess?
30.
12, 28, 25, 30. Nahin. Now again, there are two lifetime risks you have to remember. So these are two risks. So the 12% risk to develop breast cancer. This is the risk we all general population, we all have this risk, that we have risk that 12% of us would develop breast cancer and 1.3% would develop ovarian cancer. Okay, so these two lifetime risks are also important. Now, this model actually use the combined test screening. तो बेसिकली ये पूछ रहे हैं कि कंबाइंड टेस्ट में क्या क्या होता है, कौन कौन से टेस्ट है कंबाइंड टेस्ट में? कंबाइंड टेस्ट ऑफ स्क्रीनिंग, AFP है, HCG, estriol, AFP, HCG, inhibin and estriol, AFP, HCG, PAPA, HCG, PAPA, PAPA, estriol. क्या होता है कंबाइंड टेस्ट में?
It's B combined test.
देखो, हमने 3 टेस्ट पढ़े थे। सबसे पहली चीज थी कंबाइंड टेस्ट, और कंबाइंड टेस्ट हमने कहा था ये फर्स्ट ट्राइमेस्टर में होता है ना। आगे सेकंड ट्राइमेस्टर में 2 टेस्ट पढ़े थे, दैट फर्स्ट वाज द ट्रिपल टेस्ट एंड द नेक्स्ट वाज क्वाड्रुपल। ओके, यही थे ना टेस्ट, ठीक है। अब इजी वे जस्ट टू रिमेम्बर, कंबाइंड टेस्ट मैंने कहा था कि NBP, नेशनल बैंक ऑफ पंजाब, NBP कुछ इस तरह की याद कर लो, ठीक है। सो N था नकल ट्रांसलूसेंसी, एंटी, बी तो बीटा एचसीजी आ गया, पी आ गया पैपे, ठीक। तो बेसिकली उन्होंने बायोकेमिकल टेस्ट पूछा है, तो एंटी तो अल्ट्रासाउंड मार्कर है, इसलिए एचसीजी और पैप ए, सो ऑप्शन डी इज करेक्ट है। और ट्रिपल और क्वाड्रुपल में क्या था? ट्रिपल में हमने निमोनिक किया था ए बी ई लाइक ABC होता है तो ABE कर लें, और क्वाड्रुपल में एक चीज एक्स्ट्रा आ जाती है, आई। तो बेसिकली इस तरह याद कर लें कि ईस्ट्रायोल ट्रिपल से स्टार्ट होता है, इनहिबिन क्वाड्रुपल से, तो ये 2 चीजें अलग अलग हैं, ठीक है। सो कंबाइंड टेस्ट में क्या आ जाता है? NBP, सो बीटा एसओजी और पैप ए, और NT तो अल्ट्रासाउंड मार्कर आ जाता है। See this. Triple test would be having A, beta CG, E, quadruple A, B, E and I. और combined test में ये 2 चीजें. So combined test involves single appointment with above blood serum markers are taken in addition to ultrasound assessment. So अल्ट्रासाउंड में एक तो हम डेटिंग स्कैन कर लेते हैं, लेकिन इंपॉर्टेंट चीज क्या होती है? एंटी स्पेस एट द बैक ऑफ फीटल नेक। और हम ये कंबाइंड टेस्ट की विंडो टाइमिंग क्या है? ये हम फर्स्ट ट्राइमेस्टर में ही करते हैं कंबाइंड टेस्ट, दैट इज 11 to 14 weeks of gestation. Okay, so you are following up infertility clinic and note the male partner's KD type has come back as 47XYY. What phenotype would you expect to see in a male with 47XYY? phenotype क्या होगा? मतलब जीनोटाइप उन्होंने बता दिया, अब क्या होगा इसका? phenotypically मेल में कौन सा सिंड्रोम आएगा?
B.
बी क्लाइनफेल्टर का क्या होता है कैरियोटाइप?
Double XY.
डबल XY है।
Edwards.
एडवर्ड भी नहीं होता, एडवर्ड में तो एडवर्ड और ये तो है ही ना, एडवर्ड तो उसका है, ऑटोसोमल का है ना, 18 क्रोमोसोम का है, उसमें वाई तो एक्स्ट्रा होता ही नहीं है। तो बेसिकली ये जो है 47XYY हो या XXY हो, वैसे तो क्लाइनफेल्टर को हम XXY कहते हैं, लेकिन फिनोटाइपिकली क्या होता है? बेसिकली फिनोटाइपिकली तो बिल्कुल नॉर्मल होते हैं। फिनोटाइप नॉर्मल मेल, बेसिकली ऑप्शन होनी चाहिए थी नॉर्मल मेल। ऑप्शन में बाकी चीजें शायद इस तरह से होनी चाहिए थी कि किसी में एम्बिगुअस जेनिटेलिया पूछ लेते या कोई फीमेल फिनोटाइप बताते। तो बेसिकली ये XYY जो है ना, ये नॉर्मल मेल फिनोटाइप का है। ऑल्दो क्लाइनफेल्टर में भी नॉर्मल मेल है, लेकिन क्लाइनफेल्टर की कैरियोटाइपिंग ये नहीं है, ठीक है। वो एक्स वाई वाई है। अगर यहाँ एक्स एक्स वाई पूछते थे फिर हम क्लाइनफेल्टर को भी सिलेक्ट कर सकते थे, लेकिन यूजुअली क्लाइनफेल्टर में भी नॉर्मल मेल फिनोटाइप ही है। ठीक हो गया। अच्छा, इफ बोथ पेरेंट्स हैव बीटा थैलेसीमिया माइनर तो व्हाट इज द चांस ऑफ मेल ऑफस्प्रिंग हैविंग बीटा थैलेसीमिया मेजर? दोनों कैरियर है, कैरियर मल्टीप्लाई इनटू कैरियर, क्या हो जाएगा? मेजर का कितना रिस्क होता है ऑफस्प्रिंग्स में? कितना रिस्क होता है?
50% या से 25 रेशो से
कितना कितना कितना? दो दो आंसर मिल रहे हैं मुझे।
25 50 25
होता ही है ना 25 50 25 क्या? अच्छा, इसमें हम
25 दोनों कैरियर और 50 मेजर।
बस 25 नॉर्मल आ जाते हैं, फिर अगले दो बच्चे जो है ना, मतलब 50% कैरियर आ जाते हैं, और फिर एक 25% जो है ना वो डिजीज आ जाते हैं। ठीक है, तो 25 अगर पूछे कि बीटा थैलेसीमिया मेजर तो दैट वुड बी 25%। इफ दे आस्क कि कितने परसेंट चांसेस आर फॉर हैविंग द कैरियर और थैलेसीमिया माइनर तो दैट वुड बी 50%। ओके okay, so the placenta develops from which structure? That is blastocele, trophoblast, embryoblast, inner cell mass, or zona pellucida?
Trophoblast.
Trophoblast, yes, because cytotrophoblast is actually forming this placenta. So trophoblast is forming this. अच्छा जी, a bicornuate uterus is due to which of the following? Bicornuate, the two horns of the uterus.
B.
Okay, so that is abnormal fusion and reabsorption of paramesonephric duct. You all have known that it is developing, uterus is developing from the paramesonephric ducts और इसने फ्यूज होना होता है। ठीक है, so इस तरह से दो ducts हैं, ये दोनों फ्यूज होती हैं तो फिर एक यूट्रस बनती है। So whenever there is defect between the fusion of these ducts, so that would be developing these anomalies like bicornuate, the unicornuate, the septate uterus, इस तरह की सारी। मलेरियन एजेनेसिस जब आता है, एजेनेसिस मींस कि बिल्कुल ही फेलियर है मलेरियन डक्ट्स का, तो उसमें क्या होगा? यूट्रस होगी ही नहीं, एंड दैट वी हैड डिस्कस्ड इन विच सिंड्रोम? MRCH सिंड्रोम। ओके, तो मलेरियन एजेनेसिस तो MRCH में होती है, इसमें फ्यूजन प्रॉब्लम्स है। अच्छा जी, बायकॉर्नुएट यूट्रस हार्ट शेप यूट्रस होगी, इट इज द रिजल्ट ऑफ abnormal fusion and reabsorption of paramesonephric ducts during embryogenesis. मलेरियन एजेनेसिस तो ये है कि failure to form a uterus होगा। Malignant duct fusion abnormalities will be causing the biconduit malformation। और ये जो PKD1 जीन तो PCOS के साथ है, क्रॉस्ड फ्यूज्ड एक्टोपिया, ये भी हॉर्सशू किडनी बनाते हैं। अच्छा, ये फिगर है, आपने अगर देखना हो। अब इसमें क्या है? फर्स्ट द डाइडेल्फस। डाइडेल्फस में क्या होता है? वो दोनों फ्यूज नहीं हुई, वो दोनों अलग अलग उन्होंने अपने अपने यूट्रस बना लिए हैं। सी, यूट्रस भी अलग है, इसमें क्या होता है? दो यूट्रस हैं और ये नीचे देखें तो दो सर्विक्स भी होती हैं। सो दो यूट्रस और डाइडेल्फस इसको कहते हैं। टू यूट्रस और टू सर्विक्स होंगे। यूनिकॉर्नुएट का मतलब है एक ही कॉर्न है, दूसरी साइड का जो पैरामीजोनेफ्रिक डक्ट थी वो ही अब नॉर्मल मींस रुडिमेंट्री हो गया। ओके, सो एक ही डक्ट जो है ना वो डेवलप किया है, सो एक कॉर्नुआ टाइप होगा, यूनिकॉर्नुएट यूट्रस है। ओके, सो आर्कुएट, सेप्टेट और सेप्टेट पार्शियल, सेप्टेट कंप्लीट। अब ये वाली जो प्रॉब्लम्स है, जो सेप्टेट बाइकॉर्नुएट, इसमें क्या होता है कि अब ये जो दो पैरामीजोनेफ्रिक डक्ट हैं, ये जब नजदीक आएंगी इन्होंने फ्यूज होना होता है। ठीक है, तो यहाँ से बेसिकली तो ऐसे होती है ना, फिर ये वाली वॉल, ये जो सेप्टा है, ये आस्ता आस्ता डिसॉल्व हो जाएगा, अब्सॉर्ब हो जाएगा। तो अगर ये सेप्टा ये अब्सॉर्ब ना हो, सेप्टेट रह जाए, सेप्टा अंदर प्रेजेंट रह जाए, तो दैट वुड बी सेप्टेट। तो इट इज कंप्लीट कि ये देखें बिल्कुल सेप्टा दो दो यूट्रस बनी हुई है, सो दैट इज सेप्टेट। और ये पार्शियल सेप्टेट है कि यहाँ से फ्यूज हो गई हुई है और यहाँ से सेपरेट है। और आर्कुएट में जस्ट फंडस जो है ना, इधर से ऐसे एक आर्क आर्क टाइप शेप, ये आर्कुएट है, ऐसे ऐसे शेप आती है। तो आर्कुएट इसकी कुछ भी इतनी सिग्निफिकेंस नहीं है। और बाइकॉर्नुएट में भी इस तरह से कि दो कॉन्स आगे से बने हुए हैं तो इस तरह से डिप, और बाय कॉन्वेट अगर कंप्लीट कर दें तो बिल्कुल ही अलग से, बिल्कुल एंड से समझें, सर्विक्स से ही बस यूनाइट है, बाकी सेपरेट बने हुए हैं। सो ये सारी abnormalities इसकी फेलियर ऑफ अब्जॉर्प्शन ऑफ पैरामेसोमेट्रिक डक्ट है। ओके, सो द सेकंड, अच्छा जी, ये अब जो एम्ब्रोलॉजी के टॉपिक है उसमें सबसे इम्पोर्टेंट टॉपिक है फ्रेंजल आर्च है। ये तो फिंगर टिप्स पे होना चाहिए। एक फ्रेंजल आर्च का टेबल और
सी
एक
में
एक्टोडर्म और एंडोडर्म जो है ना, उसके क्या चीज,
सी
सी, हाँ जी, हाँ क्वेश्चन मैंने पढ़ा है भी। हाँ, द सेकंड फ्रेंजल आर्च स्ट्रक्चर, सो दैट इज द सी मसल्स ऑफ फेशियल एक्सप्रेशन। अच्छा जी, इसके अंदर ये टेबल देख लें तो हमने पहले पढ़ा हुआ सारा। सो फर्स्ट फ्रेंजल आर्च मसल्स ऑफ मास्टिकेशन आ जाएंगे, तो मैक्सिला, मैंडिबल, ये वाली बोन्स आ जाती हैं। और सेकंड में मसल्स ऑफ फेशियल एक्सप्रेशन आ जाते हैं। और अब नर्व्स इजी वे था रिमेम्बर करने का, फर्स्ट के साथ फिफ्थ नर्व है, फिर सेवन है, फिर नाइन है, और फिर दोनों के साथ टेन है। ठीक है? और इसमें एक चीज डिफरेंट थी कि फर्स्ट फ्रेंजल आर्च में इनकस और मेलियस आ रही है, दो बोन्स मिडल लेयर की, और स्टेपियस जो है ना वो सेकंड में आ रही है, और इसलिए आर्टरी भी स्टेपिडियल सेकंड में आ रही है। ठीक है, सो फर्स्ट में एक्सटर्नल कैरोटिड और मैक्सिलरी आ रही है, फिर थर्ड में कॉमन कैरोटिड और इंटरनल कैरोटिड है, फिर सब क्लेवियन है, फिर लास्ट में पल्मोनरी आर्टरी डक्टस आर्टेरियोसस है। और थर्ड में कौन से मसल्स है, स्टाइलोफरेंजियस है, फिर फोर्थ में क्रिकोथायरॉइड है, और सिक्स क्रिकोथायरॉइड एक्चुअली लेरिंक्स का ही है। तो इंट्रिंसिक मसल्स ऑफ लेरिंक्स सिक्स में आते हैं एक्सेप्ट क्रिकोथायरॉइड। तो क्रिकोथायरॉइड जब भी आ जाएगा तो ये आपका फोर्थ आ जाता है। अच्छा, यहाँ पे फिफ्थ नहीं है, ठीक है, फिफ्थ हमारी रुडिमेंट्री होती है, वो एब्सेंट हो जाती है, कोई स्ट्रक्चर नहीं डेवलप होता। ठीक है, तो मोटी मोटी सी इसमें जो नर्व्स और मसल्स है ना, ये बस इतने जो हायर है इतना भी कर लें तो दैट इज इनफ। ओके, सो व्हाट इज द इनोवेशन टू सिग्मोइड कोलन? सिग्मोइड कोलन, अब सिग्मोइड कोलन किस पार्ट का आ जाएगा, कौन सा पार्ट है? इट इज द पार्ट ऑफ हाइंड कट। तो हाइंड कट का नर्व रूट क्या आ जाता है? ये आ जाता है ना, T12L1। ये देखें, ये इंपॉर्टेंट स्ट्रक्चर्स हैं, वही एम्ब्रोलॉजी, फोरगट, मिडगट और हाइंडगट। अब फोरगट के स्ट्रक्चर सारे पता है आप लोगों को, esophagus, from esophagus से सेकंड पार्ट ऑफ duodenum तक। then there is the liver is developing, liver gallbladder, they develop from liver bud, you remember embryology, there's spleen, pancreas or lower respiratory tract. So the innervation of foregut is T5 to T9, and that is celiac trunk blood supply. Midgut starts from duodenum to the colon, और इसकी नर्व सप्लाई T10 और 11 है, T5 to T9, T10, 11, and then T12, L1. Okay, so P mesenteric and P mesenteric artery. तो ये थोड़े नर्व रूट्स मोटे मोटे हैं, दैट इज लिंक टू एम्ब्रोलॉजी। सो जब भी वो पूछेंगे सिग्मोइड कोलन का क्या नर्व रूट है, या मिडगट में से कोई पूछ लेते हैं कि सीकम का क्या है, तो T10, T11। ओके, so just easy way to remember T5, T9, T10, 11, 12 or L1. Okay, from which germ layer does the anterior pituitary develop? So anterior pituitary, it develops from endoderm, ectoderm, intermediate mesoderm, paraxial mesoderm, or
एक्टिवम
ectoderm. Yes, that's great. तो anterior pituitary it develops from ectoderm. Specifically अगर देखें तो आपकी वो oral ectoderm से जो एक Redkins pouch निकलता है, so that forming the anterior pituitary, और posterior pituitary हमारा ऊपर से आता है, so that वो nervous tissue से develop हो रहा है। So basically दोनों ही ectoderm का ही part है। तो ये बस आपकी oral ectoderm से out pouching ऐसे निकलती है। तो anterior pituitary posterior जो है ना, nervous tissue से down आता है। अच्छा जी, which of the following statements regarding placenta and fetal-maternal circulation are false? False बतानी है आपने जी। Deoxygenated fetal blood arrives at the placenta via two umbilical arteries. ठीक है, oxygenated blood returns to the fetus via single umbilical vein. There is no direct mixing of fetal and maternal blood at the placenta. ठीक है, मिक्सिंग नहीं होती। At term, placenta receives 70% of uterine blood flow. And umbilical vein pressure is approximately 20 millimeters mercury. So what is false in these structure, these options. So basically ये very important, ये इसमें percentage है कि at term आपका placenta uterus basically it receives 90% of blood flow. Okay, so this option is false. Okay, from which germ layer does the myenteric plexus of GI tract develop? So myenteric plexus वही जो आपका GI का nervous plexus होगा. न्यूरल क्रेस्ट ऑफ एक्टोडर्म, यस यही है, इसमें न्यूरल क्रेस्ट ही आपके सारे इनके लेयर्स होते हैं. अच्छा जी, अब जीआईटी में आपकी ये सारी लेयर्स आ जाती है ना, एंडोडर्म, मेसोडर्म और न्यूरल क्रेस्ट. सो न्यूरल क्रेस्ट है बेसिकली सारे पेरिफेरल न्यूरॉन्स आपके देने होते हैं ना, न्यूरॉन्स एंड नर्व्स ऑफ सब म्यूकोसल और मेंटलिक प्लेक्सस. और एंडोडर्म आपकी एपिथेलियम, म्यूकोसल ग्लैंड्स, सब म्यूकोसल ग्लैंड्स ऑफ जीआईटी. और मेसोडर्म में आपका जो मस्कुलैरस पोर्शन आ जाता है ना, मस्कुलैरस और एडवेंटिशिया, दैट इज फ्रॉम द मेसोडर्म. इवन कनेक्टिव टिश्यू आपका ब्लड वेसल्स का. ठीक है, सो द एंडोडर्म, मेसोडर्म और ये न्यूरल क्रेस्ट से आपका नर्व प्लेक्सस, सारी बॉडी में नर्व प्लेक्सस न्यूरल क्रेस्ट से आता है. ओके, so during formation of midgut, foregut and hindguts, the initial gut tube undergoes a rotation. So कितनी rotation होती है midgut की? So rotation is also very important. कि midgut rotation कितने degrees होती है और clockwise या anti clockwise क्या होती है?
270 होती है मैम.
हाँ 270 होती है, हमने कहा था. और एंटी क्लॉकवाइज ही होती है. फर्स्ट हमने कहा था 90 डिग्री होती है, फिर उसके बाद 180 डिग्री हो जाती है. ठीक है, सो 270 डिग्रीज आपकी एंटी क्लॉकवाइज रोटेशन है. अच्छा जी, अगेन फ्रेंजल आर्च आ गई आपकी जी. थायराइड कार्टिलेज, क्रिकोथायराइड मसल कौन सी थी फ्रेंजल आर्च? क्रिकोथायराइड फोर्थ. जब भी ये क्रिकोथायराइड आएगी फोर्थ, जब भी को बाकी लेरिंग्स के मसल्स आ जाएंगे तो वो आपने सिक्स्थ पे चला जाना. ठीक हो गया. अच्छा जी, which frontal arch gives rise to no muscular or skeletal structure? So कुछ भी नहीं, no structure developing. So that was the rudimentary frontal arch, or that is fifth frontal arch. Now, several mechanisms have been proposed as to what causes closure of ductus arteriosus at parturition. So, which of the following is the most important in maintaining the patency of ductus arteriosus during pregnancy? So, basically, the ductus arteriosus आपका pregnancy में open रहता है ना, ठीक है? तो क्या चीज है जो उसको ओपन रखती है? डक्टस आर्टेरियस. कोई प्रोस्टाग्लैंडिन्स होते हैं, कोई डी. अब E1 है E2, बेसिकली तो दोनों ही करते हैं, लेकिन ज्यादा जो प्रोस्टाग्लैंडिन है ना वो PGE2 करता है. ठीक है, सो PGE2 इज इम्पोर्टेंट फॉर पेटेंसी ऑफ डक्टस आर्टेरियोसिस. अच्छा जी, इसमें आ जाते हैं. सो द मोस्ट इम्पोर्टेंट केमिकल आपका PGE2 है. अब आफ्टर डिलीवरी क्या होता है, हाउ दिस लीड्स टू डक्टल कंस्ट्रक्शन. सो बेसिकली फर्स्ट तो आता है कि इंक्रीज इन आर्टीरियल फ्लूइड, वो आपके ऑक्सीजन प्रेशर इंक्रीज होता है. डिक्रीज इन ब्लड प्रेशर विद इन द डक्टस ल्यूमन ड्यू टू द पोस्टनेटल डिक्रीज इन पल्मोनरी वैस्कुलर रेजिस्टेंस. अब वो पल्मोनरी वैस्कुलर रेजिस्टेंस कम हो जाती है, लंग्स आपके इन्फ्लेट होते हैं, तो प्रेशर में कम हो जाएगा. एंड देन देयर इज डिक्रीज इन PGE2 ड्यू टू लॉस ऑफ प्लेसेंटा. बेसिकली जो ये प्रोस्टाग्लैंडिन E2 है, दैट इज कमिंग फ्रॉम प्लेसेंटा. तो प्लेसेंटा इज रिमूव्ड नाउ आफ्टर डिलीवरी. तो PGE2 जब रिड्यूस होता है तो ये इसकी क्लोजर में करता है डक्टस आर्टेरियोसिस. And then PGE2 receptors also, they are reduced. Oxytocin has a role, and actually it closes 1 to 2 days after delivery. So ये underlying mechanisms ये सारे आपको important करने हैं याद कि PGE2 basically कम होता है और arterial oxygen pressure it actually increases after delivery. Okay, so from which germ layer does the kidney develop? So basically हमारा यूरोजेनिटल सिस्टम कहाँ से डेवलप हो रहा था? यूरोजेनिटल सिस्टम. यस, तो यूरोजेनिटल सिस्टम इंटरमीडिएट मेसोडर्म से है सारा, आपका यूरिनरी भी और जेनिटल भी. ठीक हो गया. सो व्हाट प्रोसेस चेंज अ स्पर्मेटोगोनियम इनटू अ प्राइमरी स्पर्मेटोसाइट?
Maturation.
Yeah, this is maturation. It is not meiosis 1 2, डिफरेंशिएशन भी नहीं है, स्पर्मियोसिस भी नहीं है. अब ये कुछ पॉइंट्स है. So spermatogonium first it mature into primary spermatocytes. Okay. इसको स्पर्मेटोसाइटोजेनेसिस भी कहते हैं कि स्पर्मेटोसाइट्स बेसिकली बन रहे हैं. तो स्पर्मेटोसाइटोजेनेसिस तो प्रोडक्शन होता है. अब ये स्पर्मेटोसाइट्स क्या करते हैं? ये बेसिकली प्राइमरी स्पर्मेटोसाइट्स they have to undergo meiotic divisions. So first meiotic division होगी, secondary spermatocyte बनेगा, फिर another meiotic division होगी तो spermatids बनते हैं. Okay. So this process, whole process is called spermatidogenesis. Spermatid. Okay. So name से ही आपको पता चल जाएगा. Spermatidogenesis is actually the formation of spermatids. Okay. And then these spermatids actually जो स्पर्मेटोजोआ बेसिकली फाइनल जो आपका मेच्योर सेल है दैट इज स्पर्मेटोजोआ. तो एक्चुअली स्पर्मेटोज डिफरेंशिएट इनटू स्पर्मेटोजोआ, इसको कहते हैं स्पर्मियोजेनेसिस. तो दीस थ्री processes are different: spermatocytogenesis, then there's spermatidogenesis, then there's spermiogenesis. Okay. तो स्पर्मियो से इस तरह याद रखते हैं कि स्पर्म बेसिकली स्पर्म्स जेनेसिस है. तो स्पर्म स्पर्मेटोजोआ ही होते हैं. ठीक है. सो ये फिगर है, इट इज इम्पोर्टेंट. सी स्पर्मेटोगोनियम ओगोनियम. फर्स्ट तो आपकी ग्रोथ और मैचुरेशन होगी, तो दैट गोस टू डेवलप इनटू प्राइमरी स्पर्मेटोसाइट, प्राइमरी oocyte. ओके. देन दे एंटर द meiosis 1. meiosis 1 हुई, सेकेंडरी स्पर्मेटोसाइट्स बनी, सेकेंडरी oocytes बने. अब मेल में क्या होता है कि 1 प्राइमरी स्पर्मेटोसाइट है तो वो 2 सेकेंडरी स्पर्मेटोसाइट्स में कन्वर्ट होगा. ठीक है. और आगे से सेकेंडरी स्पर्मेटोसाइट्स फिर से 2 स्पर्मेटिड्स में कन्वर्ट होते हैं. ओके. सो एक प्राइमरी स्पर्मेटोसाइट से टोटल 4 आपके स्पर्मेटिड्स जनरेट होते हैं. ठीक है. ऐसे ही होता है ना. अब लेकिन फीमेल में क्या है कि प्राइमरी oocyte अगर एक है 1, तो सेकेंडरी oocyte एक ही बनता है, और एक पोलर बॉडी है. पोलर बॉडी तो समझे रिमूव हो जाती है, इट्स रिलीज. तो फर्स्ट पोलर बॉडी रिमूव होती है, फिर देयर इज अनदर meiosis 2, देन 1 like spermatid, so इसको हम oocyte कहते हैं, and the second polar body it generates. And then the spermatids and oocytes they differentiates into the final जो हमारे germ cells इसको कहेंगे, that is spermatozoa and the ovum. Okay. So these steps are important. कि meiosis 1 में अब आपसे पूछ सकते हैं कि क्वेश्चन के meiosis 1 में फाइनल सेल क्या बनता है. So after meiosis 1 there is secondary spermatocyte and secondary oocyte. और meiosis 2 के बाद बेसिकली spermatids बनते हैं और oocytes बनते हैं. Okay. And then they undergo differentiation into ovum and spermatozoa. So which of the following structure developed from mesodermal somites? Somites. So basically somites आ गया हमारे. Somites हमने
रिब्स.
रिब्स कहाँ चली गई मैं. ठीक है. सोमाइट्स आ रहे थे हमारे कहाँ से, पार एक्सियल मेसोडर्म से. ठीक है. याद है ना. इसमें हमने कहा था कि इसके कुछ होते हैं स्क्लेरोटोम्स और डर्मोमाटोम्स. ठीक है. तो डर्मोटोम्स माटोम्स. सो बोन और कार्टिलेज जो है ना आपके स्क्लेरोटोम से बनता है. सो रिब्स. अब देखें एपिडर्मस तो नहीं यहाँ से बनता, न्यूरोक्रेस्ट भी डिफरेंट है, लिवर और पैंक्रियास ये दोनों आपकी है एंडोडर्म की. ठीक. सो रिब्स जो है ना आपका बोन और कार्टिलेज इट इज डेवलप्ड फ्रॉम द सोमाइट्स. नाउ व्हाट इज द प्रिंसिपल आर्टेरियल सप्लाई टू द जेजुनम. ओके. सो जेजुनम कहाँ पे आती है, कौन से एम्ब्रियोलॉजिकल ओरिजिन है. सो जेजुनम का एम्ब्रियोलॉजिकल ओरिजिन आ जाता है मिड गट. सो मिड गट के ब्लड सप्लाई आ जाती है सुपीरियर. यस. पीएम मेसेंटेरिक आर्टरी. नाउ अगेन फ्रेंजियल आर्च आ गई है. स्टर्नल कैरोटिड आर्टरी. स्टर्नल कैरोटिड आर्टरी कहाँ से बन रही थी, which फ्रेंजियल आर्च?
फर्स्ट.
Yes. Okay, so approximately how many oocytes are present in the ovaries at birth?
सी.
See, 1 lakh है, 1 million है, 1 lakh है शायद. अच्छा जी, नहीं 1 मिलियन है, 0 डिफरेंट है। 1 लाख में 5 है, 1 मिलियन तो 10 लाख है ना। अच्छा, इसमें मैक्सिमम आपने याद रखना सबसे पहले। सो बेसिकली 5th मंथ ऑफ जेस्टेशन 20 वीक्स पे आपके 6 to 7 मिलियंस होते हैं, तो मिलियंस में भी इसको याद रखें। बर्थ पे आके ये रिड्यूस होके 1 to 2 मिलियन रह जाते हैं। और प्यूबर्टी पे जाके, मतलब फ्रॉम बर्थ टिल प्यूबर्टी जो आपके 13-15 ईयर्स हैं, तो वो मिलियंस से फिर अब ये लैक्स में गए हैं, ठीक है। तो 3 लाख तक हो जाते हैं, क्योंकि वो ऐसा ऐसा एट्रीजिया में एंटर हो जाते हैं, क्रिटिक हो जाते हैं। अब इस 3 लाख में से भी देखें तो ओनली बेसिकली जस्ट 400 follicles will go on to release ova at ovulation. Okay, so basically just 400 follicles ने ovulate करना है during a woman reproductive life, and more than 99 follicles, 99% follicles अगर आप देखें कि कहाँ वो 6 to 7 मिलियन और कहाँ वो सिर्फ 400 follicles आपके, they undergo atresia, and only less than 1% they undergo ovulation as well. So that is the end of our today's discussion of FPS. Okay, तो ठीक थी सब डिस्कशन। एक्टिवली वैसे आप लोगों ने पार्टिसिपेट भी किया, दैट्स गुड। और ये 3 मॉड्यूल सब कंप्लीट हो गया सबके? कोई कंफ्यूजन अप टिल नाउ किसी की?
नो मैम।
ठीक हो गया। कोई क्वेश्चन पूछना हो कुछ भी, या कुछ कुछ मुश्किल लग रहा है पढ़ने? चलो सही, चलो फिर, ओके, गुड लक देन। लेट्स एंड और today's discussion.